Hello, this is Gabriel Altit. I'm a neonatologist at the Mitral Children's Hospital, and I will be presenting you today a workshop on echocardiography related to the apical views. And a lot of the material that we will be using will be based on what is currently available on the Neocardial Lab website. So just a disclaimer, this material is really for the purpose of education. And the hope is for this material to be useful for trainees when learning some of the basic views used in the context of neonatal echocardiography. Obviously, you want to complement your learning with mentorship and readings using appropriate dedicated material, as well as following your local guidelines and practices whenever using echocardiography. At our local institution, echocardiography in terms of clinical use is a partnership with the cardiology division. And we obviously have safety mechanisms involved with paxing of all the images within a shared server, as well as reporting of the findings and collaboration with cardiology to ensure that there is, with neonatology, mechanisms to refer all the patients for which there might be new findings that were previously undetected, and that might be involving some structural defects that might be picked up on some of the functional echoes. But today, the workshop that we will be doing is really related to the apical four-chamber view in the context of neonatal echocardiography. And hopefully this workshop can be used by trainees from various disciplines, as well as if you are learning in the context of becoming an imaging technologist. So I will share my screen and we will go on the Neocardial Lab website. So this website is available for free, and we are a believer that of free dedicated educational material. And on the website, you will find different sections, one of them being a targeted neonatal echo, which contains an atlas of their normal echocardiography views. So today we will be looking at apical views. The apical view is definitely one of those views that will provide you a lot of information. Basically, the heart is divided in different sections, and we won't do an entire review of the structural approach to echocardiography, which is really something that should be dedicated to cardiology trainees. And so I will not go into the Van Praag or the Andersonian approach to the structural assessment of the heart, but we will look more at the use of echocardiography in the context of either research functional data extraction or the use of it in terms of functional assessment. And I often hear the question about, oh, can I get a sense of, eyeballing cardiac function? And, functional assessments on its own is an entire science. And requires a lot of learning and dedication, as well as mentorship and experience. But we will try to go through some of the basic concepts. So as you know, the heart is divided in four chambers. There is the atrium, which you have a right and a left atrium in the context of normal morphology. And the right atrium will connect to the right ventricle, and the left atrium will connect to the left ventricle. This will be, a session on the base of the fact that we are assessing a patient with normal cardiac morphology. As you know, there are different segments to your heart. There's the venous return. So on the right side compartment in normal morphology, you get typically the inferior vena cava and the superior vena cava connecting to your right atrium, which will then fill your right atrium. And then your right atrium will eventually empty into the underlying ventricle, which is typically the right ventricle. And typically the right ventricle is the subpulmonary ventricle. Usually, the left ventricle is being filled by the left atrium, which receives blood from the pulmonary veins, and the left ventricle is the subaortic ventricle. The right ventricle and the left ventricle are obviously two muscle pumps that are working in synchrony together. Typically, you will have electrical activation in the sinus node area, and there's wave propagation from the right atrium to the left atrium, and then it arrives at the AV node, which is a station that will slow down conduction, and eventually your AV node will activate your septum, and then you will get ventricular activation. The right ventricle will pump into the pulmonary artery, and then the left ventricle will pump into the aorta. And typically the two circulation are not connected to each other. Now we know that during fetal life and in the initial neonatal life, some of the fetal shunts may remain open and provides information between the relationship between the atriums or between the outflow tracts. So for example, we know that the ductus arteriosus, which is a connection which has the form of a tube between the pulmonary artery and the aorta, will progressively close in the postnatal life because you are exposed to a higher level of oxygen, as well as to a stop of the prostaglandins coming from the placenta. And then usually term babies will tend to close their ductus in the first 24 hours, but it could go up to 48, 72 hours, and some babies even close their ductus later, up to like 10 days of life. And so typically, while the pulmonary vascular resistance are dropping after birth quite exponentially and progressively to reach pulmonary vascular resistance that we keep in childhood and in adulthood at around 8 weeks, 6 to 8 weeks, sometimes even 3 months of age. But definitely the PVR will drop drastically after birth and continue to drop progressively. So the PDA will typically give you information between the outflow tracts, so the aorta and the pulmonary artery. And if it remains largely open, there will be, pressure transmission from one compartment to another. Typically, the SVR are higher than the PVR in the postnatal life, and as such, usually the shunts goes from the aorta to the pulmonary artery, and we say from the left side to the right side. And so it brings a systolic and diastolic pressure transmission to the pulmonary vascular compartment, as well as increased flow transmission, which will rise the QP-QS, which means there's more pulmonary blood flow compared to the systemic blood flow. And there's a certain degree of steal effect from the systemic circulation to the pulmonary circulation. And all of this may have some impact on your cardiac loading conditions. So for example, your right ventricle will be facing suddenly higher pressures because some of the pressure from the systemic compartment will be going to the pulmonary compartment because the two compartments are connected to each other. So whenever you have two compartments that are connected by a tube, and then you rise the pressure in one compartment, that pressure can be transmitted to the other one. And so your RV will be facing this increased pressure on the pulmonary outflow tract level, while the left ventricle might be receiving excessive blood flow because you get that degree of over-circulation of blood and increased QP-QS for the pulmonary circulation. And because of that, you get more blood flow coming back to your pulmonary veins. Your left atrium eventually dilates. Eventually, you get some degree of mitral annulus dilatation. Because of that, you get some degree of mitral regurgitation. And eventually, you might even have some degree of LV dilation because of overfilling. And then eventually, your aortic valve will also dilate, and you can get some aortic insufficiency. So these are kind of various stages of excessive pulmonary venous flow coming back to the left-sided heart. Now, the two ventricles will act together, but they have different conformation. The atrium also have different conformations and geometrical configuration. And the valves, as you can see, are also implanted not at the same level. So typically your tricuspid valve will be implanted a bit lower than your mitral valve. And actually here you can see it quite well, where your tricuspid valve, which has tri-leaflet, typically compared to your mitral valve, which has 2 leaflets, will not be implemented at the same level. And one of the very common features of an AV canal, atrioventricular canal, is that the 2 atrioventricular valves are on the same level. So that's definitely one of the differences that you would see between a morphological normal heart and a heart that corresponds to an atrioventricular configuration. So going back to our atriums, the atriums may also have one of the fetal shunts that are persistent, and often in babies we would see some degree of interatrial shunt, which could be because there's a patent foraminovalle which stays patent in many newborns and even throughout adult life and pediatric life in many, if in a big percentage of the population. And some epidemiological research has shown that it could be up to 20-25% of the population that have some degree of patent foraminovalle. And then typically after birth, that what happens is that with the drop of pulmonary vascular resistance, you get more pulmonary blood flow. Because you get more pulmonary blood flow, you get to fill a bit more your left atrium. And eventually, as you know, those valves, the tricuspid and the mitral valve, during diastole, they open with their corresponding ventricles. And when they open, they get to fill these ventricles and the pressure will equalize from the atrium to the actual underlying ventricle. Knowing that there's a filling phase, typically the pressures are extremely low during the filling period. So between 0 to 5 millimeters of mercury, knowing that there's like that suction effect that happens at the level of the ventricular cavity. And so at the end of diastole, when these valves are open, the atrioventricular valves, the pressure between the atrium and the underlying ventricle will be the same. And typically, as your PVR are dropping, as you get some remodeling, and as you get this myocardium a bit more thickened by the fact that it's exposed to the systemic vascular resistance, which are higher than the PVR, you will get a slightly higher end diastolic pressure in your left ventricle compared to your right ventricle. And then your shunt at the level of the interatrial shunt will become left to right and eventually close that flap of the PFO. But in the first few days of life in newborn, it's very common to see relatively bidirectional shunts at the level of the atriums. And typically, to look at your interatrial shunts, the apical 4-chamber view is definitely not a good view to do that, especially in babies. You want to use the subcostal view because of the angle of insonation. As you can see, we lose some of the areas of the septum in apical 4-chamber view. And definitely that's not something of a view that you can really appreciate reliably what's happening at the interatrial zone. So just as a recap, if we look at the apical 4-chamber view, typically we will have the apex close to our zone of ultrasonography. If you're doing adult or emergency point of care ultrasound, you're going to see that the convention of ultrasound is quite different. So in pediatric, in most echo lab, we will have the pie towards down, and we would have the left ventricle towards the right side of the screen. And this represents the right ventricle, this represents the left ventricle, this represents the left atrium, and this represents the right atrium. And in this view, we can even appreciate a bit the pulmonary veins. And so that's the convention in most pediatric echo lab. And what I say to trainees often is whenever you're doing an echo with the tail of your probe towards the leg of the patient, typically your pie will be inverted. So for example, typically your subcostal view and your apical 4-chamber view or apical 3 or 2-chamber view will be with the pie inverted. And whenever the tail is above, whenever you're scanning with your tail towards the head, so for example, the parasternal long axis, parasternal short axis, your suprasternal view, your PDA view, and your crab view for the pulmonary veins will typically have the pie with the standard nomenclature, such as they use it also in the adult echo labs. A few other pointers to recognize, especially for those that uncommonly will scan patients with congenital heart defect, is that the left ventricle and the right ventricle have very much morphological properties that are assigned to them. And they do come from different embryological sources. And although they do share some myocardial fibers, typically they will be very independent in their structural growth, and they will have very peculiar particularities that identify them. So for example, typically the muscle of the LV will be in generally quite smooth, and the papillary muscle of the mitral valve will always attach to the free wall, which is here. It will not attach to the septal wall. The right ventricle typically will have the tricuspid valve, which is usually trileaflet, will have some papillary muscle layer that will come to the septum, which is very specific to the right ventricle. And the other thing is that the right ventricle will have something called the moderator band, which is also one of the anatomical landmark of the right ventricle that sometimes we can see by echocardiography too. So here you can see that we've attached the ECG, which allows us to have a sense of the time of activation of the ventricles, and so to time the systole and diastole. And typically we would look at the different frames to see whenever it's the end of systole or the end of diastole, and typically the end of systole will be at the max of contraction of your ventricles. And your end of diastole would be at the max of filling. And sometimes in some babies, these may not occur exactly at the same time for the right and the left ventricle. So this is another example of the apical four-chamber view, where we can see that the tricuspid valve is a bit lower than the mitral valve here. The mitral valve is named mitral because it comes from the hats of certain popes that looked, well, actually the valve looks a bit like these hats. So here you can see that this is an apical four-chamber view, which is trying to delineate the entire left ventricle, looking at the apex area, because it's very easy to miss the apex. On this particular scan, you don't see necessarily where the focus is placed because some machine will have autofocus, but always make sure whenever you scan that you want to optimize your imaging. So you want to really narrow it down to whatever structure you're looking, especially if you're doing some functional assessment. You probably want to narrow your sector to really include the left ventricle. You want to make sure that you have the entire endocardium that you can delineate so that you can see the entire cardiac cycle. And you want to make sure that you optimize what we call the frame rate, which means how many images you're going to have per second. So the frame rate allows you to have more granularity in terms of looking throughout the cardiac cycle, especially in the context of pediatric echocardiography, where the heart rate is much higher. You want to have more information per cardiac cycle. So the left ventricle has typically a bullet-shaped structure. And because of that bullet-shaped structure, a lot of the mathematical assumptions to calculate the volumes of our left ventricle are based on the assumption that it has a bullet-shaped configuration. Now, because it has a bullet-shaped configuration, it's important to also look at both the septal wall and the lateral wall of the ventricle, but also to look at the anterior wall and the posterior wall of your ventricle, so that you're able to localize some dyskinesis of some of the myocardial segment that may happen in some patients. This is a really good diagram that's available for free on internet, on Google. It just allows you to delineate which segment you're looking at when you're looking at a left ventricle. So you can see that you can have the apical four-chamber and the apical three-chamber view, and eventually you can even switch to an apical two-chamber, four-chamber, and the three-chamber view. And this allows you to have a sense of the different segments that you're seeing from your left ventricle, whatever zone that you're cutting. So here you have the inferior areas and then the anterior areas of the left ventricle. So each time we speak about the base, typically we speak about the area that is just under the auricular ventricular valve. Then we have the area that's the midway, and then you have the area that is the most inferior portions, the apical portions, and then you have the apex area. And you can see that here, this is the lateral wall and the septal wall in apical 4-chamber. So this is kind of reversed because it's the adult way of showing the sectors. This is your 2-chamber view, and this is what you would see if you would take like an apical 3-chamber, where you see your left atrium, you see your outflow tract, and then you see some of the anteroseptal areas with your outflow tract and your aortic valve and your LVOT, which is here, and then your aorta with the sinotubular junction here. Don't forget that if you do have certain diseases like congenital heart defects, you might have a situation where your LV is connected to your pulmonary artery, such as in some of the transposition of great arteries. And so at this point, this configuration might not be exactly the same. There are really great resources actually that you just, could look on also Google outlining, the ways and the different segments. So here, for example, it shows you what exactly are you seeing when you're doing an apical view. So we were talking about the apical 4-chamber view with the LV here and the RV here. If you're looking like this in the chest, you would see your apical 2-chamber view with the section looking at the anterior wall and the section looking at more of the area that is considered the posterior wall. And then if you're looking in that angle, you would see basically the zone with your outflow tract, which is your aortic valve here. And as you can see, the aortic valve and the mitral valve have what we call fibrous continuity between each other in a normal morphological heart. So basically your mitral valve here and your aortic valve are in fibrous continuity. And this is a great view to outline if there's any signs of LVOT obstruction, especially in some certain diseases like infant diabetic mothers, which some of them may have some degree of septal hypertrophy. And because of the septal hypertrophy, they may have issues with, first of all, diastolic function. So the filling becomes problematic, but at the same time, they may get like dynamic obstruction of their outflow tract during systole. So we often see some intracavitary acceleration if we put some color Doppler on the LV in the apical 3-chamber view. And then the other thing that you may see is what we call systolic anterior motion of the mitral valve, because there is hypertrophy and there is the mitral valve in systole that comes and kind of kisses the wall of the septum, and it obstructs the outflow tract. So that's one of the concerns when we see patients in the neonatal period with some degree of hypertrophic cardiomyopathy, such as in the context of infant diabetic mother. So this is just to give you kind of a sense of how it looks like when you put it relative to the cross-sectional area. So apical 4-chamber view, you will have a sense of your RV lateral wall, your septal wall of the RV, and then the septal wall of the LV, and then eventually your LV lateral wall. In apical 3-chamber view, you can see that you have your outflow tract, you have your atrium, and then you have some degree of your LV that is both anterior and posterior. And then eventually your 2-chamber will cut the anterior and posterior section of your LV. Now, if you translate your probe and this line like just here, you could also appreciate the anterior inflow portion of your right ventricle and the, your anterior outlet portion of your right ventricle and your posterior inlet portion of your right ventricle. So you could see, for example, your tricuspid valve emptying with the posterior wall and the anterior wall with the outflow tract and the pulmonary artery. So we will show this view of the RV so that you're able to assess both the lateral wall and the septal wall, as well as the anterior and posterior wall. So I'll go back to, this is our 2-chamber view. And then here we can put color Doppler to see the flow in the mitral valve. Just as, a reminder, flow coming towards your probe, which is here, is red, and flow going away from the probe is typically blue. So you can see that when the mitral valve will open, you get this red flow, which is the filling from the left atrium to the left ventricle. And this is an example of, where we're putting our focus. So if you want to see more of the apical contraction, you should probably bring your focus down. And just so you see here, you have here lines with dots or lines with dots here, which is your cursor line. And really the distance between these 2 points is 1 centimeter. So this distance corresponds to 1 centimeter on the image. So when we look at functional assessment, one of the very commonly used metrics for echocardiography derived functional assessment of the left ventricle is trying to remodel the volumes of the left ventricle. And there are multiple techniques to do that. But one of the techniques is using what we call the Simpson's biplane disc method. So using that techniques, you can then calculate the ejection fraction, which is basically how much of that volume gets ejected in systole. So here, this is an example of the calculation of ejection fraction, which is the left ventricular estimated end diastolic volume minus the left ventricular estimated end systolic volume, and all of this divided by the same value here, which is the left ventricular end diastolic volume that's estimated by echo, times 100 to get it in percent. Now, an ejection fraction in the newborn period, you have to remember that often in the newborn period, your PVR are still slightly higher than what you would get into the childhood period. And because of that, during systole, you might get some degree of flattening of your septum, and the whole configuration of the left ventricle, which is supposed to be bullet shape, might not be totally true. So that's why I say estimated, because if you get flattening of your septum, those discs are not really discs when you outline them, and the estimation of your volumes might be a bit underestimated or overestimated, depending on how you do your calculations. So here you can see that typically we would take an apical 4-chamber and apical 2-chamber view. The equation of the estimation of the volumes, which is done by typically your data extractor, will be this. And it basically sums all those discs that are traced in systole and in diastole. So here we have a representation of our LV in diastole. So with the valve being closed at the maximal volume, and you trace really your endocardium to blood interface. So that's why you would want to have your entire apex. So it's not even like the best example here. You would probably want to make sure you see your entire apex, which we kind of see here on the line here. And you don't include any of the trabeculations. And same thing in systole, you want to go and really trace your entire end systolic volume. And then this would estimate your end diastolic and end systolic volume in 4-chamber. And you're able to calculate an ejection fraction using these estimates. So for example, if you're doing a calculation just with whatever you traced in 4-chamber, it would give you 64% for this patient. But to maximize your measurements, you would want to do the same thing in apical 2-chamber view. And you want to make sure to take your images sequentially, because you don't want to, you want to take the opportunity to have as much as possible the same loading conditions and the same heart rate, because some of the loading conditions and heart rate might change also your configuration and your function. So here you can see that we trace the end diastolic volume with valve closed, and the same thing we would do end diastolic volume with the valve that's closed. So it allows you to also have an end systolic and end diastolic volume using those discs methods and calculate an ejection fraction in apical 2-chamber. And then when putting all of those discs in the different views together, you're able to also calculate a Simpson biplane measurement. Now, this obviously provides you information about the LV function if there's no anatomical anomalies. If, for example, you have important mitral regurgitation, then obviously a lot of blood flow, whenever there's contraction, will empty out into the left atrium, because it's much easier to go backward into the left atrium, which is a low pressure chamber, than to eject into the aorta where there's high systemic vascular resistance. And so as such, your EF might falsely look normal, but the LV function might not actually be completely normal in a setup where, for example, you have severe MR and some aortic stenosis, or if you have other degree of anomalies. Also, if you have big VSDs and a lot of the volume transmission goes to your right ventricle, you might also false your assessment of underlying LV function. And so there are other techniques to quantify or to estimate the LV performance, and that's just one of them. And also for measurement of ejection fraction, that's just one of the techniques. Here, this is an example of putting the color box over the tricuspid valve, and we can see that when the valve is closed here, there's a bit of jet going towards the right atrium, which indicates that there's some degree of tricuspid regurgitation. And if you would put this box over the mitral valve, you could also try to appreciate if there's any degree of mitral regurgitation, but also if there's some degree of mitral acceleration, which could be there in the setting of some degree of stenosis. You can use the jet of the TR or the jet of the MR to calculate something called dPdt of the underlying ventricle, and we'll go there later on, since the dPdt is a way to have some information of underlying LV function, especially useful in the context of single ventricular functional assessments. So let's go to our right ventricle. This is an example of where you see your right ventricle, your tricuspid valve at the peak of systole with this blue jet, which means that the blood is going from the right ventricle to the right atrium. And you can use your continuous wave Doppler in order to estimate the peak of velocity along the line of interrogation. So there's many things that I just said that I want you to pay attention in. So when we use continuous wave Doppler versus pulse wave Doppler, the difference is that the continuous wave Doppler is that we're asking the machine to provide us information about the velocity of the blood flow being interrogated all across the line of the cursor. So for example, here I have my cursor line, or here I have my cursor line, and you can see how the machine is being asked to estimate whatever velocity of blood flow that it's picking up across that line of interrogation. The pulse wave Doppler, the difference is that actually it will interrogate the velocity of the blood flow wherever you have put your cursor. So it's not across the line of interrogation, it's just at wherever your cursor is. And typically, pulse wave Doppler are used to estimate inflow velocities as well as outflow velocities. Whenever there's low flow velocities, such as coronary, it's a good use. But whenever there's like very high flow, such as in obstructive lesions, aortic stenosis, or in situation of MR or TR, you want to use your continuous wave Doppler. And then here, what you can see is that you have your QRS, you have the start of your contraction of your right ventricle, and then this is the TR that we're able to obtain. And eventually you get a slope of deceleration, and then you have your diastolic phase, and then it restarts. And the peak of your TR typically will appear at the peak of systole. And at peak of systole, if there is a flow through a narrow point, you can use the Bernoulli equation to estimate the pressure gradient between the two cavities. So the velocity of blood flow informs you about what velocity there is between the blood flow of cavity A to cavity B. Here it's 3.54 meters per second. And so if you put this into the modified Bernoulli equation, which is 4v squared, so 4 times velocity, gives you an estimate of a 50 millimeters mercury of gradient between your RV and your RA at the peak of systole. It informs you about the peak RV systolic pressure, and that might inform you about the peak systolic pulmonary arterial pressure if there is no big VSD, or if there is no pulmonary stenosis, or if the outflow tract of the RV is indeed a pulmonary artery. So if you're in a TGA, that will inform you on the systemic blood pressure. And so because we assume that the right atrial pressure is between 0 to 5 millimeters of mercury in most normal infant, you add 50 plus 5, and it gives you an appreciation that the peak RV systolic pressure is around 55 millimeters of mercury. Now I say we estimate the RE pressure to be between 0 to 5 because you are sometimes in a situation where you have so much RV dysfunction that you have some degree of diastolic dysfunction. So filling pressures are very high, and the right atrium is not able to empty out into the right ventricle, or worse, there's backflow into the right atrium, and eventually, if you have a PFO or an atrial septal defect to pop off your right atrium, you might get some right to left shunting at the PFO level or the atrial level, and your RE pressure might actually be a bit higher than 5 millimeters of mercury. So we'll see that in patients with like severe pulmonary hypertension, or in situation of like vein of Galen malformation, or AV malformation, arteriovenous malformation, such as at the liver. These patients come with torrential blood flow coming back to the right atrium, which basically the compliance is not enough to compensate for the amount of blood flow that comes back. The RE pressure are very high, and typically these patients have a bit more than 5 millimeters of mercury. So if you put like a umbilical venous catheter and you reach the right atrium, you would see that there's a lot of backflow coming back. And if you would measure that backflow and get a sense of your right atrial pressure, you would see that it's much more than 5 millimeters of mercury in this context. So another thing that you can use is what we call the DPDT. That has been used in some contexts of, like, for example, hypoplastic left heart syndrome, to get a sense of the right ventricular systemic ventricular function. So, for example, what is the DPDT is basically for the right ventricle is the time interval that it takes to reach from 1 to 2 meters per second. And for the left ventricle is actually from 1 to 3 meters per second. So I will show you here. There's a great example on the site of the Canadian Society of Echo, which I have put here, the link. So it tells you here that you can use the time from 1 to 2 to reach 1 meter to 2 meters per second. And then it's likely considered to be abnormal if you're able to generate less than 400 millimeters of mercury per second. What does that mean is here, you can see that this is 1 meter per second, this is 2 meters per second. And if you trace the time that it takes to reach from 1 to 2, so basically that little narrow time, so from 1 meters per second to 2 meters per second, there's, you know, a few microseconds that are here. And this time tells you that it was able to generate a lot of pressure during 1 to 2 meters per second. If the curve was like this, right, it would tell you that it takes more time to generate that pressure. So that's one of the ways to quantify pressure generation in some of these single ventricular anomalies. So that's another example of a mitral regurg. In this patient, it's 5.45 meters per second. If you put it in the Bernoulli equation, you get 119 millimeters of mercury. And if you add an estimated RE pressure of 5, you would get a RV systolic pressure of 124 millimeters of mercury, which is quite high, obviously. There's a whole section and workshop on pulmonary hypertension, so I will let you listen to that workshop. Here, the color box has been placed on the mitral valve, and you can see that there's 2 little narrow jet of mitral regurgitation. These are these kind of 2 blue flames. So in systole, while the mitral valve is closed, there's blood flow going back towards the left atrium. And sometimes, there might be some physiological MR in some of the newborns, but we will see some of those babies that had some degree of perinatal depression, hypoxic ischemic encephalopathy, where the LV has suffered also a hypoxic hit, that they might develop some degree of MR. And one of the reasons is that the watershed areas of the heart are typically that zones of the papillary muscle. So typically the papillary muscle will have difficulty contracting and kind of holding up these mitral valve while the ventricle is being contracted. And so you could start seeing appear some degree of mitral regurgitation in newborns that underwent hypoxic ischemic encephalopathy. So this is another example where you can actually even see the jet of a pulmonary vein coming into the left atrium, which is not the best views to look at pulmonary veins, but that's an example of, one of the pulmonary veins one of the upper pulmonary veins coming into the left atrium. And then you can Doppler these pulmonary veins and you would get these biphasic to triphasic waves, which are typical of the pulmonary venous flow. So here, another example of the biphasic flow of the pulmonary veins, which in the newborn period is important to evaluate because some of these babies may have some degree of partial or total anomalous pulmonary venous return. And obviously the PA-PVR and the ATA-PVR will not present at all the same way. The anomalous total pulmonary venous return, typically these babies are cyanotic, they get blood flow coming back to their right atrium, and so you have this obligatory right to left shunt through the atrium so that you get some filling of your left atrium, and so these babies are blue. And then some of these patients even have an obstruction of their pulmonary venous flow, and they end up in severe pulmonary edema, and it's quite a surgical emergency. The partial pulmonary venous return, anomalies of pulmonary venous return, will really act like an ASD. These patients will have higher blood flow to their right atrium, and eventually you get increased QPQS, and then eventually you get excessive volume into your RV. Your RV is volume overloaded, and eventually with time, if it's under-recognized, you can get increased pulmonary arterial pressures because of the the secondary volume remodeling of your pulmonary vasculature. So what about EA velocity ratio? What is EA velocity ratio? So typically, and that comes a lot from the pediatric and adult literature, and mostly the adult literature. I am mentioning it, but be cognizant that this has been mostly validated in the pediatric and adult population, and that in newborns, because the heart rate is so high, typically these waves are fused, and because the compliance of the ventricles are very much different than what you would see in the pediatric or the adult population, all of these measurements, which are typically used for diastolic function and filling function, are yet to be formally validated and are sadly very imperfect. So here is an example of a pulse wave Doppler. So you can see that the difference is that the machine will show it to you as two lines, at least for this particular machine. And this tells you that you're actually probing your inflow velocity, so the velocity at the mitral valve opening. And so you can see this velocities. Typically what we would do is we would put our color blocks over the mitral valve, make sure the flow looks laminar, and then really localize the area of the most inflow by color, and eventually probe with a pulse wave Doppler, which really provides us with the velocity of blood flow at the point of interest. So it's not along the entire cursor line, it's just at the point of interest. And what do we see here? This is the inflow of the mitral valve. We can see that there's a first phase and then there's a second phase. And what are these two phases? So typically we talk about the early phase and then the atrial phase. In most ventricles that are of normal compliance, when the mitral valve will open, you get a lot of influx of blood flow, and the majority actually of your filling of your ventricle occurs during that first part of the diastolic phase, which is typically a phase where your valve is open and your left atrium will actually percolate into the left ventricle. So typically when you do a pulse wave Doppler at the inflow, either for the LV or the RV, if you will see these two phases of filling. And the first phase of filling is called the early phase, and the second phase of filling is called the A phase, which stands for the atrial kick, or the late phase. So here you can see that the maximal velocity of the blood flow filling the left ventricle in that case happens during the early phase of the diastole of the left ventricle. And then as the atrial will contract, you get a second phase of velocity. So you get a peak velocity, which here is about 0.8 meters per second. And then you have an A velocity. And the ratio between these velocities will tell you and gives you some information about these compliance of the underlying ventricle. So in a very good compliant ventricle, the majority of the filling will occur during the early phase. And so typically the velocity and the peak of the velocity will be bigger during the early phase compared to the late phase. So your E on A ratio is typically above 1 in what we call a low compliant ventricle, so in appropriate diastolic function. The issue is that in many of the newborns, the heart rate is very fast. And because it's very fast, you get a fusion of these waves. And so you'll often see that there is only a one phase. The other issue is that typically, in the neonatal population, especially at the beginning of life, and especially if you're premature, the compliance of your ventricles are still changing and getting remodeled. First of all, because you're still immature and you're growing. Second of all, because you've just been exposed to the fetal circulation. So the normative values, which you can go under here in TN echo and then normative values, you would find this table that is from this article referenced here, which basically shows you that typical path of early to late phase. So the early phase occurs often during the T wave of the electrical activation and repolarization. And then the A phase, A wave will typically occur during the P wave because it's the atrial contraction. And so as you're getting some degree of abnormal diastolic dysfunction, you start seeing a reversal of these waves, phases. And that's typical to see in patients that have some degree of diastolic dysfunction. So either because they have restricted filling, such as a poor relaxation of the ventricles. So you can think about certain diseases like cardiomyopathy or hypertrophy, especially in newborns of infant of diabetic mother, or patients with Noonan syndrome will have some degree of cardiomyopathy, or even in the context of exposure to steroids, where you might have some degree of ventricular hypertrophy, or glycogen storage disorders, Pompe disease, which this tends to become progressive. And really, some of these patients can become quite tachycardic because they have poor filling and eventually poor output. And the body tries to compensate by activating the heart rate to improve the output. But the problem of that is that by increasing your heart rate, you decrease your filling time. And by decreasing your filling time, you end up with even less output, and this becomes a vicious cycle. So a lot of these patients that are very tachycardic with signs of poor filling, one of the ideas could be to try to rate control them to improve their filling time. But obviously, it really depends on the underlying etiology and clinical presentation to address kind of the management of these patients. So E on A may provide you some information, and the E on A may also be altered by the loading conditions. So for example, in patients with a PDA, with a lot of pulmonary vascular flow, you might also have alterations in your atrial filling. So depending on the volume of the shunt that goes through that ductus, when it's left to right, you get more and more pulmonary venous flow and more left atrial filling. And because of that, this may also alter your, you can see that, for example, in this patient's, at least qualitatively, the LV looks much bigger than your RV, and there might be some element of, excessive LV flow from the pulmonary venous return. But also, you will see that there are some scoring systems that will look at the E on A phase. So for example, if you see here, this is one of the echocardiographic indexes used in the assessment in the left or right shunting of the PDA, and especially preterm neonates. It was done by Dr. Jain and Dr. Shah. This is the article, and in their table, it's quite nicely put together, but you can see that the ratio of early to late diastolic inflow velocity across the mitral valve becomes more than 1. So basically, they have a very high E wave and a shorter A wave, which in many of the preemies or many of the term babies in the first few days of life, you actually get a very similar velocity. So the ratio is about 1, or sometimes even because of the compliance of the ventricle, which is still very muscular and less compliant than whatever you would find in a term baby, sorry, in a child. Often your ratio is even less than 1 in normal newborns. So these values in terms of quantification of diastolic function are not yet as much validated in the immediate newborn period than in the pediatric and adult world. So this is another example of an E on A wave that you can see are unfused. In the adult population and adult echocardiography world, they will also look at some of the deceleration slope of your E wave. And they will look at some of those other values, such as timing values or areas of this relationship. The same pattern, and this is just to give you an example, you can see that here on the RV compartment side at the inflow of the tricuspid valve, you can also see the E and A wave of the filling of the right ventricle. And you can almost see that here it's completely fused. And this is another example of a patient where you have sometimes the A wave that is bigger than your E wave, or E and A wave that are kind of at the same level. So a ratio close to 1.0. So these are your inflow velocities. It is important to look at inflow velocities, but also to probe them to ensure that you don't have signs of tricuspid or mitral stenosis, because sometimes you might get some acceleration during the diastolic phase of filling because there's an obstruction at the level of the mitral or tricuspid orifice. This is quite rare in the neonatal period, but it could still happen, and one needs to be kind of accustomed to that. And so locally in our protocol, we'll always have measurements of the inflow velocities of the blood flow for both the tricuspid and the mitral valve to ensure that we don't have signs of acceleration. You can also use the inflow velocities to a certain degree to assess whenever you have pericardial diffusions. So I'm going to go on to, we have a specific section on the website about pericardial diffusions. And if you go here under effusion, the idea is that a pericardial effusion becomes a diastolic problem, because if it's at a point of creating a tamponade effect, it means that it's restricting the filling of your ventricles. And if it's restricting the filling of your ventricles, it really causes diastolic dysfunction, which means that then your ventricle are not able to get filled. And one of the ways to assess by echo the hemodynamic impact of that is that you can look at the variation of filling, both of your right ventricular inflow or your left ventricular inflow. So typically, in the situation of an important pericardial effusion, you can get some degree of restricted filling. Here you can see it's still the inflow, so it's a PW at the level of the tricuspid valve, again at the tricuspid valve, again at the tricuspid valve. And then we put a PW, but we basically elongate the time. So we allow ourselves to look at the variation in time of the velocities of our inflow velocity. So you can see that for the tricuspid valve inflow, there's some articles quoting that normally with a normally breathing infant, you would have a variation that is, the normal should be less than 40% of variation, versus the mitral variability should be less than 25%. So whenever you compress your time, you can look at your velocity and mark your peak and of the highest inflow versus the lowest inflow. And if you're having more than 40% on the RV compartment side or more than 25% on your LV compartment side, you would have issues regarding your diastolic velocity and concern about some tamponade effect in terms of filling. And I've put here the referral regarding the article pertinent to pericardial tamponade and the use of inflow velocity patterns. And we'll talk about the fact that when you look at your pericardial fluid for an effusion, typically your subcostal view will be one of the best views to look at anterior to posterior, posterior to anterior about the localization of your fluid. And typically we tend to measure it whenever the patient is at the full diastole. So whenever your ventricles are completely expanded, that's when you'll measure the diameter of your pericardial effusion. So here, this website outlines very nicely some of the assessment of the hemodynamics and the goals of the echo exam. And so it outlines some of these measurements in terms of, looking if it's localized versus circumferential, looking at some of the assessment of elevated intrapericardial pressure, as well as some of these markers that I just mentioned of markers of pulsus paradoxis. So if you have increased tricuspid inflow variability or increased mitral inflow variability, these are signs that there could be some elements of pericardial tamponade. So this is where you might use your inflow velocities for the tricuspid side and your mitral side in neonates. And you can see this is an example where your E is lower than your A wave. And then for both the tricuspid compartment and the mitral compartment, the mitral inflow velocity. And these could be within normal limit in the context of newborn population. In the adult population, there's been a lot about the left ventricular velocity of propagation as a marker of LV diastolic assessment. This has not been very well validated in the neonatal population, so I will not discuss about this, but I did put a reference here on the website. Then we have a nice view of our outflow tract in the apical through chamber view. And you can see your left atrium, you can see your mitral valve, and you can see your left ventricular chamber with the mitral to aortic fibrous continuity. And this is a good view to, first of all, assess blood flow going into your outflow tract and make sure there's no obstruction. It's also a good view to evaluate if there's any sign of aortic insufficiency or mitral valve insufficiency. And it's also an excellent view to try to align your probe to measure any signs of aortic obstruction or LVOT obstruction if you have a subaortic obstruction, either that's functional, such as if you have hypertrophy and systolic anterior motion of the mitral valve, or in the situation of, for example, subvalvular aortic stenosis or valvular aortic stenosis. It's also a good view to put your cursor at the tip of the valve or in the area of the valve to be able to assess what we call the velocity time integral of the LV outflow tract. So this is another example where we actually visualize the blood flow going into the LV outflow tract. We can see that there's minimal AI, where there's this little flash of red dot, which is quite physiological and not of concern in a neonate. And then here you can see that our cursor is at the area of the valve, and we're able to have a pulse wave Doppler really at the area of interest, which is the cursor. So on the y-axis, you have the velocity, and on the x-axis, you have the time. And basically, if you trace the area, you can have an area under the curve, which will give you an estimate of the stroke distance exactly at that area. So how much did a PRBC traveled during that time point, the distance of traveling. Some clinicians, as well as researchers, mostly in the TN echo world and much less in the cardiology world, we'll use this equation to have an assessment or have an estimate of what we call cardiac output. This is a controversial measurement, especially in the cardiology world, because you have to measure your LV outflow tract in the parasternal long axis view. And you assume that your diameter corresponds to the diameter of a circle. So using this equation. So obviously, because the LVOT diameter is put to the square, and because we assume that it is a circle, this measurement is quite imperfect. And so it uses the heart rate at the time of the measurements of the LVOT VTI. It uses the VTI as a measure of stroke distance, and then it uses the diameter you measure in the parasternal long axis view in order to estimate the cardiac output, which in the context of newborn is often expressed in milliliters per kilo per minute. So you have to divide it by the weight of the patient at the time of the echo. So that's an example of an LV outflow tract PW. So you can see that there's those two lines. That the machine is then telling you over time and the velocity, what is the velocity at the valvular area of your LVOT. And then by tracing your outflow velocity, you can have what we call a velocity time integral. And it tells you that basically you are at 11.2 centimeters of stroke distance at the time of your assessment. So you would typically use this VTI with the corresponding heart rate, which is 149 based on the ECG here. But you could also calculate your exact heart rate at the time of the actual measurement of your VTI using one cycle to one cycle measure. And based on that, you can calculate your cardiac output using an assessment of your stroke volume, your heart rate, which is your VTI times your cross-sectional area times your heart rate. This measurement has been controversial in the cardiology world because obviously of the reasons that I mentioned regarding diameter measurements of your LVOT, which is prone to mistake and is also squared. So there are some controversy about that, but it's been used in the context of research, especially from when you look at the neonatology literature. And it's been used especially to assess excessive cardiac output, such as in the context of very significant ductal shunts that are left to right. So these are examples of an aortic VTI in the context of a patient that really had low output. And you can see how this measurement just of the stroke distance is very low. And that actually has been used in some of the literature looking at ECMO whenever you start weaning your ECMO to look at the underlying cardiac performance. And there's some data that shows that it's quite a sensitive measurement that can help you start weaning your ECMO. And there's some literature from the group of Stanford on that, led by Dr. Teresa Tapsy at the Stanford group. And that's another example of a VTI here, where you can see that the VTI is quite, when you measure it at 2 moments, it's quite similar, 0.055 meters and 0.057 meters. This is what we call apical 3-chamber view of the RV. So just as a reminder, when I mentioned you could do a 2-chamber view that is anterior to posterior of your LV, you can translate your probe and have the same view of your RV. So you have the anterior portion of the wall of the RV and the posterior portion of the wall of the RV with your tricuspid valve, which is your inflow. You can see that in the middle, there is this aorta coming from the middle portion of the heart, which basically comes out of the LV that is just behind. And you can see here that this is your pulmonary valve or your RV outflow tract. So this is a nice view so that whenever you're doing your apical views, you can look at the lateral and septal wall of the RV, but then you can turn and you can see also what's happening on the anterior compartment and the posterior wall of your RV. One caveat is that we know that the majority of the function of the RV comes from the longitudinal function. And so most of the measurements of the RV function has been done based on the apical four-chamber view, but more and more data, especially coming from the group of Dr. McNamara and Dr. Giesinger, as well as some of the Toronto group, like Dr. Amish Jain, when looking at the functional echo measurements, a lot more publications are coming out using this particular view to have an assessment of RV function. So based on that, you're able to assess your inflow and your outflow, and sometimes it's a good view to try to align yourself to get a TR. So then if we start looking at RV function can be estimated using the using echocardiography. Markers of RV function can be, one of them is what we call fractional area change. Basically, the RV has this shape that looks like a banana with your inflow that is posterior and your outflow that is anterior. And then basically you get this longitudinal push of the blood towards the outflow track. And so when you're looking at the apical four-chamber view, one of the measurements that has been described is what we call fractional area change, which typically is an area at the end of diastole with valve closed, tracing the contour at the level of the endocardial blood interface and not including the trabeculations. And then you can do this measurement at the end of diastole and at the end of systole and do a fraction of that. So typically it's the RV and diastolic area minus the RV and systolic area divided by the RV and diastolic area. And usually in a lot of the available literature, what's been described is that having an FAC above 35% is considered normal and will correlate with RV ejection fraction by MRI. But this is particularly true for the pediatric population. The group of Phil Levy from who's now in Boston has described that, you know, the FAC will change slightly with age, knowing that the RV will also adapt to the pulmonary vascular resistance and its afterload, the resultant afterload after the delivery. And also it may be impacted a bit by gestational age at birth. So there's more literature looking at, you know, when you look at all gestational age together, ballpark, if you have a FAC that's below 29%, that seems to be associated with worst outcomes in terms of situations where you have pulmonary hypertension. So locally, we've been using a cutoff of about 29% as a marker of RV dysfunction. One of the more sensitive markers is what we call Tapsy, which is the tricuspid annular plane systolic excursion. The Tapsy is basically doing an M mode. So the M mode will outline time on your x-axis and the movements of your pixels along the line of interrogation on the y-axis. So you can see here that when the valve is positioned at the end of diastole, it's positioned here. And as the ventricle starts contracting and your valve is starting to slide down inside the RV cavity, your tricuspid valve the tip of your tricuspid valve is actually plunging inside the RV cavity, and the peak at systolic excursion will give you a sense of this longitudinal functional property. So what we're interested in is the actual distance that this tricuspid valve will go through the cardiac cycle during systole, and gives you a sense of systolic function of your RV. And so you can see that the measurement here, because basically this is one line of interrogation, and the movement of this valve is what we trace along the x-axis with time. And this distance here, so the distance between the peak of diastole and the peak of systole, will provide you information about the systolic function of the right ventricle. And so if you go in the normative section, I have put some of the normals that have been described in the neonatal population by gestational age. And Tapsy has been one of the most reproducible measurements for RV functional assessment in the newborn period. So here you can put Tapsy, and then you have some of the Z-score calculators for the RV function that's been provided by the website called Parameter Z. And it's been derived from some of the data of the group by Kostenberger. And so you can select the age, either the gestational age, or if you're looking at a child or pediatric adolescent age, this will provide you a Z-score calculation. So for example, if you take a baby that's born completely at term and you submit it by centimeter, 1 centimeter, which is 10 millimeter, will be around a normal value, and it will trace it along the gestational age groups. So if we go back, so this is for Tapsy. So that's one of the elements that you can assess in the apical 4-chamber view. This is an example again. One way to derive it from the 2D images, which is more imprecise because you don't have the high frame rate from the M mode, is to actually trace your end diastolic area. Like if you would be doing your fractional area change, to trace your end systolic area, and then to bring the 2 points that are apart as a measure of your tricuspid valve movement. And there's pretty good correlation between this method and the M mode method, although the M mode method is the preferred one. Whenever you're doing your M mode, you want to make sure that the line of interrogation will pass at the level of the tricuspid valve attachment to the free wall and the apex. That's the idea whenever you're doing a Tapsy. Whenever you're also measuring your RV function, or you have a concern about RV function, other indirect measurements that you can look at is RV dilation, or mean pulmonary artery dilation. So there are standards by the American Society of Echo for measurement of your pulmonary valve annulus and parasternal short axis, your main pulmonary artery, your right pulmonary artery, your left pulmonary artery, as well as the measurements of your RV. So you can have a longitudinal measure of your RV at the end of diastole. So when the RV is at its max capacity with valve closed, you can measure the basal area, so just under the tricuspid valve, and you can measure the mid-cavity area. And there are some normative Z-scores by age or body surface area that are available, and you can find that link here on Parameter Z. So if you go to Parameter Z, you'll be able to get linked to some of these Z-score calculators. You can also do a planimetry of the right atrium in order to see if there are some signs of RA dilation. And typically the planimetry will be done at the level of end of systole of your ventricle, which corresponds to the moment that the right atrium is the most filled. And so usually it's done when the valve is closed, the tricuspid valve. These are just some of the tables regarding the Tapsy by gestational age, but also providing you with the mean of the Tapsy that's measured. So you can see that at 41 weeks, the mean of their population, 18 newborns, was 1 centimeter or 10 millimeter, versus at 40 weeks, it was around 9.5. And you can see that they provided the standard deviation. So for a patient to have 7 millimeter of Tapsy at 40 weeks, it's probably a sign of RV dysfunction. So we're going to go into the category of tissue Doppler imaging. What is tissue Doppler imaging? Is that the concepts of Doppler, which is to provide you assessment of the velocity of movement using ultrasound, can be applied to both blood, and we've seen it with continuous wave or pulse wave. So as a reminder, continuous wave is across the line of interrogation, and pulse wave is where you selected your cursor. So specifically at the moment of the cursor, at the place of the cursor. A tissue Doppler imaging is really to look at the same concept of velocity assessment, but using movements of the tissue, so movements of the myocardium. So you can apply these concepts by putting your cursor just under the attachment of the tricuspid valve or under the attachment of the mitral valve in order to assess the longitudinal movement and function of your myocardium during systole and diastole. So this is an example of a tissue Doppler imaging for a right ventricular free wall just under the tricuspid valve. And here you can see that on the y-axis, you have the velocity of the movement of your tissue. And on your x-axis, you have time. So you can see the actual ECG with your QRS and your T waves. So what do we see here is that, first of all, you can see that this line that is in the positive side is whenever you have movements that are coming towards the probe. And whenever you're in the negative side is when you have velocity of movement that's going away from the probe. So if it's positive, it means that your valve or your myocardium is coming towards the probe, which tells you that it's during the systolic phase of the cardiac cycle. The amount of frame rate and the granularity, the temporal granularity of information is very high in tissue Doppler imaging. So you're able to have a sense of the entire systolic phase of the cardiac cycle, as well as the entire diastolic phase of the cardiac cycle. And typically, you'll get a first portion in systole that's called the isovolumetric contraction time, which is basically this first spike of the myocardial wall that's starting to move because there is a contraction, but there's not ejection. At the moment of the outflow tract valve opening, which in the context of the right ventricle is typically the pulmonary valve, you start getting movement and velocity of your myocardium contracting and going towards your apex. And so you have velocity buildup of your myocardium, which ends up with a peak that we'll typically call an S prime velocity for systolic velocity. So the peak systolic velocity of the myocardium free wall of the right ventricle will inform you on the right ventricular longitudinal function. Now, the caveat is that, as you can see, it's highly angle dependent. So the way that you're visualizing your image will highly influence these measurements. So you want to make sure that you're as aligned as possible with the wall that you're interrogating. And the other thing is that it will inform you only on a portion of the myocardium. But obviously, if you start having a lot of infarcts or zone of myocardial wall that are not working, you would possibly expect that the peak velocity at which you're going to get your contraction will be reduced. So whenever you have S prime reduction, it could be a sign of RV dysfunction or LV dysfunction in the correlate of the LV. You can apply the same concept when looking at the diastolic phase. So typically, when we look at Dopplers, we always take what we used to say, we take the chin, not the beard. So you'll see some of these extension here, like here. And what you want is actually take, the crispest area of your Doppler as your measurement of your peak. Same thing for pulse wave and color and continuous wave Dopplers. Never take the tip of the beard, always take the tip of the chin. So here, this would be the first phase. This would be the diastolic phase of your TDI. So basically your ventricle is re-expanding. And the first part of the re-expansion, which you can see here, this timing here, the time here corresponds to the isovolumetric relaxation time. Eventually, your tricuspid valve or your mitral valve will open, and then you get filling, and then you get expansion of your myocardium, either from the RV or the LV side. And during this expansion, you get two phases. So similar to what we saw with the blood, you get an early phase of filling, and then you get an atrial kick. So we typically speak about the E prime velocity, which is the peak of that first wave, and then the A prime velocity, which is the peak of that second wave. And so one way to assess diastolic function that's been very popular, especially in the adult population, is to look at the ratio between the peak E wave on the blood flow Doppler at the inflow divided by your E prime wave of the tissue. And as your compliance is getting worse, or as you're getting more diastolic dysfunction, you're starting to have more of an increased ratio of your E to E prime ratio, because it means that your E prime wave is becoming less and less important. So if your ratio is the E wave on the E prime, if suddenly you get a very low E prime wave, which means that your muscle is stiff and not moving so much while it's getting filled, your ratio will start rising. And so it's been a marker of diastolic dysfunction that has been studied, but mostly in the context of older pediatric and adult functional echocardiography and diastology. It's much less been studied in the context of the newborn period. So this is an example of S prime, E prime, and A prime wave of the RV free wall. You can have similar measurements of your TDIs at the level of your LV free wall. Typically, you want to be positioned just under the mitral valve where it attaches to the free wall of the left ventricle and at the peak of diastole. So you would probably position it just here whenever the LV is fully expanded, and you can see the same thing. So your S prime, your E prime wave here, and your A prime wave here. And you can see your systolic phase and your diastolic phase, and you can see your isovolumetric contraction time and your isovolumetric relaxation time. And the E and A prime waves might also be fused if your heart rate is very fast in the context of the neonatal population. Same thing, you could apply these concepts to the septal wall, which typically has been mostly looked for the LV dysfunction, although there is some argument that some RV dysfunction may also impact the septal wall. So in newborn, we've been mostly looking at the RV free wall and LV free wall, but the septal wall has been looked in terms of research whenever there's like dyskinesis of your septum. Obviously, if you have a big VSD, this may also impact your TDIs, and TDIs are sadly also impacted by loading conditions. So that's another example of your E prime, A prime, and your S prime, E prime, and A prime wave for your LV free wall. So as I mentioned, you can measure your isovolumetric relaxation time and your isovolumetric contraction time and your isovolumetric relaxation time, and the ejection time during systole of either ventricle using TDIs. Now, what information is that going to bring you? Well, as function or loading condition will change, you might spend more time in systolic ejection or more time in some of the isovolumetric phases. And so these will all be affected depending if you have some degree of systolic or diastolic dysfunction also. And so there is a marker that's called the MPI, or Myocardial Performance Index, that was also called the TI index. And you can use TDIs to calculate what we call the TI index. Typically, your MPI is your isovolumetric contraction time plus your isovolumetric relaxation time divided by your ejection time. And that can be done using both for the RV or the LV. And there's been normal values that has been outlined in the literature, which I provide here under normative values. So if you go in normative values, you can see some of these references, which look at both the inflow Doppler values, but as well as your E prime, A prime, S prime velocity for the mitral annular and septal, as well as the tricuspid annular. And you also have values on your E on A prime ratio, ICT, and IVRT. There's some, information about how to assess diastolic dysfunction for some of these patients using the apical four-chamber view. And then there are some normative value looking at the MPI. So for example, this is an article that was done by the group of Amish Jane from Toronto, where they scanned normal newborns at day 1 and day 2 of life as they were doing their transition postnatally, and measured the MPI as well as provided standard deviation. So as you can see, it's a curve, the MPI. So if you're too low or too high, you might be in a situation where there's some underlying diastolic or systolic dysfunction. So because we want to avoid errors coming from repeated measurements, typically to calculate the MPI, what we would do is that we would calculate the entire time period. That includes the IVCT, the IVRT, and the ejection time. And then we would measure just the ejection time. And then we would subtract this entire time period from the ejection time to get a sense of what IVCT and IVRT are. So just as a recap, if I go back, you can see here that you can measure the entire time, that is IVCT plus ejection time plus IVRT, remove the ejection time from that, and you would only get the IVCT plus IVRT, which gives you the measurement that you need for your numerator for the MPI. So in the apical four-chamber, you can also assess the left atrial planimetry as well as left atrial volumes using the apical two-chamber and apical four-chamber view. It's not something that we do typically in my lab, but it's things that are done in other institutions. To measure the actual tricuspid and mitral valve annulus, contrary to measuring the actual ventricular calibers where your valve is closed, you want to measure your tricuspid valve annulus and your mitral valve annulus when valves are open. And this is what has been recommended by the American Society of Echo. And there's a very, very nice available Z-score calculator from the Boston Children's Hospital Heart Center, where you can find normative values per body surface area or weight for these valvular measurements. So this is the module on apical four-chamber view. Hopefully, this is obviously only an introduction to how to image or how to understand some of these echo images. There is a whole other art and science surrounding how to optimize your images and how to scan. What I've shown in these modules are mostly still frames for the easiness of understanding, but we will always do in our own protocols a scan from anterior to posterior to show the relationship of the different structures. So in apical four-chamber view, looking at the LV and looking at the RV, we also sometimes probe the pulmonary outflow tract in some of those views. So if you go very anterior, you can see the outflow tract of your RV, such as outlined here, but that can also be done in apical four-chamber view. And one very important thing is that we will scan the septum to make sure that there's no signs of VSD, and really we try to look at the apical area so that we don't miss VSDs. And beware that in the newborn population, if the PVR are still high, the velocity through a VSD might not be very high if there is any flow. So make sure that you decreased your Nyquist, you decrease the velocity filter in order to be able to appreciate if there is a flow through the septum. So what I talk about Nyquist or velocity filter is exactly this area here. So whenever you're putting a color box, you can ask the machine to filter some velocities. So here, the machine will show you only the flow that has been identified to be above 0.64 millimeter per second. Anything that's below will not been shown. So if the velocity through a VSD, so that's an example where here I can discriminate that there's something going through my septum. So there's likely an apical muscular VSD, and I would need to go and actually scan anterior to posterior to see the extent of that VSD. And I can also use continuous wave Doppler to assess the relationship between the two ventricles during the systolic phase of contraction as a way to assess the difference of pressure between both sides and how restrictive my VSD is. So you can see how there's much more to neonatal and pediatric echo using these views, and how this is only an introduction. And basically, you know, a lot of what I mentioned today is applicable to normal morphology, but as soon as you enter morphological variants, there is much more to be done in apical four-chamber view. And there are some great resources out there, such as one conference given by the Chicago group on a yearly basis that also gives a nice introduction to echocardiography in the pediatric population. So I'm very hopeful that you enjoyed this workshop. And I'm very happy to suggestions or comments. So please feel free to contact us. Our email is provided here in Contact Us. And please use this material for really you know, educational purposes, and please validate everything with your own local echo lab to ensure that the normative values that you use and the experience that you have locally corresponds to whatever didactic information I provided here. So I want to thank you, and I wish you all a great day.